We have also questions from the audience. So Ursula, can you please go ahead?
Thank you very much for giving us these overviews. I was very puzzled by Trudy's comment. It's a therapy, not a treatment. For me, these two words were equivalent. Can you please explain to me the difference?
Yes, I appreciate in some countries that they're the same. When a patient hears the word treatment, they think it's going to make them better. It's treating the condition. Whereas if you say anticoagulation medication or anticoagulation therapy to reduce the risk of a clot forming, it's the patient's perception. If a doctor prescribes medication, it normally means it's going to help you feel better. Anticoagulation doesn't make you feel worse or better. It makes, so to help with adherence, we've carried out surveys with patients, and also, the patients that contact us, they will say, I've been back to my doctor several times, they're just not listening. This anticoagulation doesn't make me feel any better. When we spend time with them explaining the purpose of the anticoagulation and that they need to discuss with their doctor what treatment options are there to actually treat the pounding in their chest or whatever their symptoms are, it's almost, they go, oh, okay, I understand now. Yes, I will take this medication because I don't want an AF-related stroke, but I will go back to my doctor and discuss what treatment options there are. So whatever the language is,
I understand. Thank you. And I really like the point you are making, that some forms of therapy will not make you feel better. And to see this from the point of view of patient is certainly very important. I really like it that you pointed this out so very clearly. Thank you.
Thank you. And it doesn't take much time just saying, I'm going to prescribe this. However, you will not feel any different, but it will greatly reduce your risk of an AF-related stroke. That took seconds to say, and that can be the difference between a patient adhering to anticoagulation and wanting to discuss treatment to somebody that, some patients say, well, I've given up with my doctor and I'm not taking anything. I just have to learn to live with it. And when we hear that, obviously it's alarm bells. So something that can take seconds can have a lifetime impact on the quality of life for patients.
Thank you. We also have another question from Andreu Martinez.
So basically, thank you to all for your presentation, and I would like to make a question, trying to put together what the research projects are doing and what the patients have been discussed. I mean that one thing that it seems is that patients are not sufficiently informed about what is being done, but the question is how the research that is being done by the projects that were presented by Maria, by Daniel, by Felipe, could change the flowchart of patients or could improve the treatment of atrial fibrillation, because I think that it seems that it's only a matter of communication and not a problem of we do not know how to treat them, how the patients and how the clinicians can feel the fact that they need to change from one treatment to another because some of them are failing, and how the new technologies could help them in that way. This question is basically for all, so I don't know who.
May I just say one thing? I don't want to be the one always speaking. I'm often invited to sit on research, become a co-author, and I'm very happy to do this. And one of the things we do is to write a lay summary. And we have a database of 60,000 patients, for example. And if the research is published, we produce the lay summary and get that out to patients where it's appropriate, so that they understand as well. And again, an informed patient can sit down with their clinician and understand better and discuss better. So I think involving patient representatives such as myself and others at the point of research can also improve outcomes.
And Felipe, how do you see all these different treatment options and also the different devices that are emerging every year, let's say? How do you think they are changing the way the patients are treated? and how you envision that they will change the treatment in the future?
Well, atrial fibrillation is very difficult to treat. And as Andreu was saying, we have to be able to communicate the patient that we don't have a magic bullet to be able to treat it successfully in just a simple shot. But technologies are developing very much, and we are gaining a lot of insight from what we have been researching for the last years. So I think that we need to better understand how atrial fibrillation is. It's not a simple disease, and it's not a single disease. It is composed by many different types of atrial fibrillation. So we have to be able to separate and to better identify patients that can be successfully treated and separate them from those for whom we cannot treat properly. Because we cannot treat the same the whole amount of AFib patients with the same tool, which is drugs. You know that drugs are not very successful. Many years researching for drugs, and they didn't come out with a successful and effective drug. Ablation is an advance, but it's not a magic tool for every single patient, and it can only be delivered successfully for a certain type of patient. So the main things that we have right now are tools that will help us to better diagnose the patient. That is, to better characterize the characteristics of the patient, to identify those that will do better with certain type of drug or will succeed after AFib ablation. So the diagnostic tools that we need to perform, that is the way what we're doing right now, is to try to advance in the knowledge of atrial fibrillation. Until now, we could know atrial fibrillation using the ECG, but that is very simple, very broad. I'm talking about the 12-lead ECG. And on the other hand, you can introduce catheters, but that is a very invasive procedure. And on the other hand, the catheters are unable to get the full picture of AF, because during atrial fibrillation, the atria is constantly beating from different sides, and it's impossible to obtain a full map of the whole atria. So we need to be able to characterize AFib, and that is the way we've been conducting these ECGI studies to characterize the behavior non-invasively, in a way that we can understand how AFib is behaving in every single patient without introducing any catheter. There are many other areas that can be also used to better discover AFib, and that will be covered by Dr. Engler's study, which is being able to screen AFib. That is, being able to characterize how AFib is behaving, how many episodes are having the patients, and how can we better diagnose the patients that are having or not having recurrences from atrial fibrillation. So these two main areas that we are researching on and are part of this discussion today will represent, I hope, real advances in the knowledge of atrial fibrillation. So as an overview, I will say we need to better diagnose atrial fibrillation in order to be able to treat it successfully.
Thank you, Felipe. And now moving the question to Daniel, how do you think that, why do you think it's important to have these large databases that you have been presenting to better understand atrial fibrillation? Daniel? Maybe he lost the connection. So
he's
maybe
a clinician, he's gone.
Yeah.
Good. Hello.
Daniel, Yeah. So we were talking about these new developments and how to better learn about atrial fibrillation, not only to allow better screening of the patient, but also learn about the mechanisms of atrial fibrillation. So how do you think that the large databases will play a role in understanding better the mechanisms?
Yeah. In general, for the FACT-EU, it is it is good to have some point of view when you took this small or largest studies together to get a greater overview about the data is available, and how to harmonize it will be another question. But in general, you can say if you have some studies who were more or less can be harmonized, you have also statistical power to see how AF screening, for example, can be successful and can reduce number needed to treat, or see how can we tackle AF that is not or that is symptom free. So this approach to perform meta-analysis and to handle data like this can be have a lot of also for a lot of impact also for a governmental level when we talk about implementation of such screenings or talk about implementation of therapies.
Yeah, thank you. And what do you think will be the future in new lines of research for atrial fibrillation? Can you envision what should be the future? Yeah. How do you see the future in the research of atrial fibrillation? We have talked about the projects that we are undertaking today, but where do you see that should be the direction in research in the future?
Yeah. The direction is going more getting into the data and having this kind of big data with all the measurement tools and all the new devices we have. So we are able to perform statistical tools like machine learning with random forests, like related multiple decision trees and so on. So we have this opportunity now to have this big data and perform artificial intelligence tools and get in more that like it is a diverse field. So we will see. It is not an easy question you asked for the future. But I see to handle big data and to make the data qualitative good will be an effort for the next or will be an effort for the future.
Yeah, thanks. And one question we haven't addressed so far, and maybe both Daniel and Felipe can answer this, is managing atrial fibrillation patients. It's a very big task because there are so many patients. So it's not only that we need to develop new tools or better screen tools, but we also need to know how to manage in a whole population of patients that it's hundreds, thousands or even millions of patients in a given country. So if you think about a hospital or a service, how to manage this whole amount of patients, what are the challenges that they are facing, and how we can improve also at the management level how to treat these patients? I don't know if either Daniel or Felipe could answer.
Well, I will try, but this is a very difficult question.
It is, indeed.
It is a very difficult question because there are so many patients that we will, if we were to treat every single patient with atrial fibrillation, we couldn't do it. We would be overloaded. So the problem is that many patients just simply do not need treatment, probably because of their age or because they have several comorbidities that made it impossible to be treated. So the way that, as I was saying, the way that we need to manage patients with atrial fibrillation is trying to separate patients that are most likely to benefit from different types of treatment. The majority of patients will be treated medically, and they do not need anything else, and they can do better. But on the other hand, we have to be able to characterize patients that will and may benefit from invasive treatment, because that is the bottle, how would I say in English? I don't remember. The narrow part of the protocol. So we cannot treat every single patient invasively. We have to select patients that are going to undergo AFib ablation to better select those most likely to benefit from treatment. And that is the tough part. That is why we are focusing on being able to better select and characterize patients that most likely will benefit from invasive treatment and to undergo with them ablation, because the problem that we are seeing right now is that a large proportion of patients that are undergoing AFib ablation are not directly benefiting from AFib ablation. They have to undergo 2, 3, or more procedures, and they fail, and the patient gets discouraged, and we get discouraged. So we need to better believe how to treat patients, being able to select those that are going to benefit from the ablation procedure, and on the other hand, exclude those patients that will not benefit from the ablation but may benefit from other ways of treating the disease.
Yeah, thank you. And I know that you're not a hospital manager, but how do you think the hospital managers feel about all these treatments for atrial fibrillation?
I'm not a hospital manager, and I wouldn't like to be, because managing patients with atrial fibrillation is very expensive. It's very expensive, not only from the point of view of those undergoing ablation, but treating these patients that have to be visited and be taken care of by expensive drugs. Anticoagulants are great, and they have improved a lot in the last years, but their price is still very expensive. And on the other hand, the catheters and the systems that we need to treat invasively patients with atrial fibrillation are expensive. And on the other hand, we want to introduce new tools, either to screen patients with atrial fibrillation. I'm not talking about Holter, I'm talking about either any type of monitor, either watch-based monitor or other types of monitors are costly. So managing atrial fibrillation is expensive and is not successful. So the problem is right now, if you ask me about managing atrial fibrillation, what should we do? We should keep researching. We need to better diagnose atrial fibrillation to be able to treat it successfully.
So you're talking about screening patients and deciding which patients should be, let's say, treated for restoration of sinus rhythm, which patients shouldn't be treated this way. I wonder, Trudy, what do you think that patients feel when they say, okay, there's no hope for returning you to sinus rhythm. Let's just treat for anticoagulation.
Despair, hopelessness. They're already anxious. They already feel very vulnerable. A lot of younger patients can't work if their AF is so bad. Older patients think it's the end. We were inundated with calls from patients at the beginning of COVID and pandemic because they were so worried that they were the vulnerable high-risk group. They're already anxious because of the panicky feeling that AF gives them when they're in AF and their heart's beating all over the place. So it already has that sense of anxiety, which is only heightened if they're told there's not a lot that can be done. Yes, there is a lot that could be done, but it's accessing it. So I agree there needs to be more research. We need to look at services and patients, you know, even managing their lifestyles better, and research into how to prevent AF in the first place. You know, so I think there's lots of things that can be done, but I do think patients should and must have access to treatments wherever possible. You know, it is a major concern. It is the #1 cause of stroke. So, you know, there are things we should be doing, but it must be a nightmare for the hospital payers because, you know, it's such a large cohort of patients and it's very costly.
Yeah, and on the other hand, I also wonder, how do patients feel when they are actually treated? Let's say they are recommended to ablation and it's an invasive procedure. I don't know, they probably know that the effectivity is not 100%. And the question is, how do they feel in general, or most of them?
The majority are just relieved, even if it only lasts months or a year or a few years, it gives them relief. Most patients are willing to go back for a second, third, fourth ablation if it's worked for a period of time. They're desperate for help. You know, patients, they're more upset when they're told after their third or fourth ablation that that's it, there's nothing more they can do. They would willingly go back for yet another ablation rather than have to live the way they're living on a daily basis. I don't think any of us truly appreciate the impact AF has on the individual and how, for many, the restrictions it has on their life, their lifestyle. My own parents both have AF, and my mother's was very active, and she got to the point where she could only climb the stairs by going up on her bottom because she was too exhausted to walk up, and because of AF. So many of these patients are just desperate to have some sort of relief from the ongoing debilitating symptoms of AF.
Yeah, we have also a question from Christian Barros from Karlsruhe.
I have a question. Like, I'm just starting my PhD, so I have very little experience in research. But after hearing all of you talking, I'm curious about how often in research, in clinical research, the patient's opinion is asked. For example, we are developing this new kind of catheter screening. This is what you are going to feel. You as a patient, what do you think of this? This will be good, this will be bad. And how often that happens, and how often you just let the clinicians speak on behalf of the patient? How is the normal going on research in this regard?
Is that question for me?
It's mostly for the research, but I guess you are involved with research, so like you can say how many times they ask you to get involved, but as well for the researchers, how many times do you ask the patient's opinion about what you are doing?
Yeah, that's a good question, but I'm very strongly involved in research, and we have to consider that new devices and new tools need to be used, and we have to carefully explain the patient that they have a difficult disease and we need to improve the treatment of the disease, and that we have to try new ways to treat it. So it's a basic part of research, being able to transfer that information to the patient to make him or her believe that you are going to try your best to improve her clinical condition, giving every single explanation that they need before they sign their informed consent to participate in any type of trial that you are going to deliver.
Sorry, Daniel here. My experience is that we have from our population-based study, we have some screening tools we can test, or some one-lead ICGs, and after the informed or before the informed consent, we ask if they can wear devices that they can see how they are that they are comfortable with this device for this particular research. And we also when there is an informed consent and they participate in device studies, there are always questions. Is it feasible that a patient wear this kind of device, or is it how does the device is appropriate in all day living? Is there a quality deficit of wearing the device, and social factors will be also involved into the research study. So that's how we handle patient feelings within research when we talk about devices.
One of the things that we do often for research, we will arrange a patient advisory board to engage with the researchers as well. So you have patients from all different backgrounds and experience of, different experience of atrial fibrillation and their journey throughout the healthcare system. And they can then give the researchers, and often may have 2 or 3 meetings, one when the research is just being explored, 2 if the research gets approved, and 3 nearing the end of the research, so that the patient voice is considered at every step of the way. Because like anything, there's no point doing something if it's not what the patients need or want or feel comfortable with. I think it's very good to have, and it shouldn't be a specific doctor's patient, because often that doctor has a great interest in AF and their patients are well managed. So getting a group of diverse patients that have had good, bad and indifferent experiences gives a far better input. So that's something that we offer researchers.
Okay, thank you very much, everybody. I think it was a great discussion. It was very interesting to see the different points of view all related to the same topic. And before closing the session, I would really like to ask everybody to turn on the cameras of their computers so that we can take a screenshot with everybody connected. So please, before we say goodbye. Yeah, thank you very much. And maybe we can take a screenshot. And yeah, thank all the speakers very warmly. It was a great pleasure to have you all here. And yeah, thank you very much for the discussion and for the questions from the audience and the students that have participated as well. So thank you very much.
Thank you.
Thank you, Maria. Thank you, Maria, for chairing the session. Thank you.
Okay, thank you very
all
much.
For listening.
And yeah, and take care. Bye-bye.
Thank you. Bye-bye.
Bye.
Bye-bye.
Bye.